Starting.
Good evening and welcome to one and all present. In this session, I am Ankona from Clarnet. Clarnet is very proud to be a part of this webinar as a digital partner. Now, I'd like to play a short video of Clarnet. Thank you so much for all your patience. Clarnet is India's largest live digital CME and doctors-generated medical content platform. Our website is www.clarnet.com, where we have lots of live sessions conducted by the eminent speakers across the globe. And we have MedWiki services also, which is medical Wikipedia for doctors only, that also you can read in your leisure time. We will invite all the doctors to visit our website. Now, without further delay, I would like to hand over the session to Dr. Ria Roy, ma'am. Over to you.
Thank you, Ankana. So, very good evening to all. This is Dr. Ria Roy. I'm an executive member of IACFM, and we are very pleased to host a session on roles and responsibilities of family physicians today. Our speaker is today Dr. Raman Kumar, sir. And Dr. Raman Kumar was recently featured on the cover of the Lancet as a global primary healthcare leader and one of the first generation residency trained board qualified family physicians. He holds a strong long-standing interest in making a contribution to primary care. He is the founding president of the Academy of Family Physicians of India, AFPI, an organization that is spearheading the movement for the return of trusted family doctor tradition in India. Dr. Kumar is credited with creating a large pool of young doctors eager to pursue vocational family medicine, and he is also the editor-in-chief of the Journal of Family Medicine and Primary Care, a peer-reviewed PubMed Index journal. He has been confirmed with several awards and recognitions, which include the Healthcare Leadership Award 2012, India and Montegut Global Scholar Award 2013, with the American Board of Family Physicians, and then the Healthcare Leadership Award Dhaka 2020. He represented all the young family physicians on the executive board of the WONCA, that is a World Organization of Family Doctors, from 2013 to 2016. He is also the lead physician and chief of clinical services in Doc24 clinics and convener specialist board of family medicine, National Board of Examination, Ministry of Health, Government of India. He has championed the cause of rural population and an underprivileged section of the society. In 2018, he successfully organized the 15th World Rural Health Conference in New Delhi. The conference successfully organized culminated in the adoption of the Delhi Declaration 2018, calling for people living the rural and isolated parts of the world to give in special priority if nations are to achieve universal health coverage. So the Delhi Declaration, endorsed by WHO, revisited the Alma Ata Declaration with the aim to achieve the highest possible level of health for the communities we serve, with the goal of health for all rural people. Throughout his career, Dr. Raman Kumar sir has worked at several public and private institutions in India throughout his career and presently is practicing as a full-time family physician. He has published more than 100 research papers across national and international journals and has also been delivering educational programs, including many keynotes. So welcome, sir, to the session on roles and responsibilities of family physician. And I now hand over the session to you, sir, so you may proceed with your presentation. Thank you, sir.
Thank you, Dr. Ria, Dr. Rubina, Dr. Abhishek, team of Clarinet, for inviting me to this session. I'm very glad to be with you discussing role and responsibilities of family physicians. So we all have the memory of family physicians, family doctors. We all have perceptions, understanding, or some kind of impression of family physicians, the family doctor tradition. But more recently, because of the evolution of the discipline of family medicine across world and also in India, there is a renewed interest in what family physicians' roles should be, what family physicians are supposed to function as in the healthcare delivery system. So I'll just take you briefly through my own journey as well as how family medicine has evolved during past 1 decade, and what are the core concepts and what are the core attributes of family practice, family medicine as an academic discipline, a vocation, a specialty of medical science. So Let me share my screen first. I hope my screen is visible now.
Yes, sir, is visible.
Thank you very much. So we'll be talking about role and responsibilities of family physicians in the background of the discipline of family medicine, the specialty of family medicine, the academic domain of family medicine. So we all know who family physicians are. We all have seen family physicians probably in our lifetimes. Earlier in past decades, family physicians used to be very, very, popular healthcare providers. In the beginning, when the entire Western medical education system was initiated by the Britishers in India, all physicians used to be general practitioners or family physicians. And it was only during the recent decades, more so for after Second World War and in India, in the 80s and 90s, we had rapid development of specialties and subspecialties in India. And it same happened a couple of decades before in the Western world, developed world. Now, in response to the fragmentation of healthcare, human health into disciplines or domains or specialties, there was demand for personalized whole person care uh, in the Western world also. And traditionally, if you look in the Indian scenario, we always had, in the ancient times, the system of Vaidyas in the villages. Vaidyas were none other than the family physicians of the past. And this system continued even when we had started the MBBS course. Medical Council of India was initiated, established and till 70s or 80s, I would say. And then there was rapid escalation in the development of specialties, subspecialties. And presently, our memory has been skewed in a way that normally we understand, the hierarchical model of care providers, the physicians' roles as basic doctor, specialist doctor, and super specialist doctor. And this is how the career pathway is being presented to Indian medical graduates. And we are the largest medical education system in the world. We have 640 or 30 medical colleges in India across geography, and we have around 1 lakh MBBS seats presently, and more medical colleges are being started, initiated in many other parts of the country, especially the recent district medical college project has supported initiation of medical colleges in the underdeveloped parts of India, especially the northern part. Earlier, we had mostly our medical colleges concentrated in the southern part. 3/4 we are located in the southern part of India. So through my role as a professional leader of family physician, family medicine, and also I had opportunity to participate in the World Forum of Family Doctors, which is called WONCA, World Organization of Family Doctors. I was the president for the South Asia region, which is, you can broadly say, the SARC region, from 2018 to 20. And earlier, I was the young doctor representative on the World Board of WONCA from 2013 to 2016. And during this time, I had opportunity to travel across world. I've traveled most of the world for work related to the professional assignments, engagements. And I had opportunity to watch how the health system works in different parts of the world. What is the Brazilian health system is like? What is NHS actually like? How the African countries are developing their health systems, how it is happening in ASEAN countries like Thailand, Philippines, Indonesia, Malaysia, and how the developed parts of the world organize their healthcare systems. We as physicians, doctors are very proud of our own medical education system, and we very proudly say that we have the best medical education system. Our graduates do well internationally. We see them doing well in NHS of UK and the US also. A large chunk of doctors are from Indian origin. So but my own experience, if we compare our health system and medical education system, we are at least 20 years behind the many similar countries, like even Brazil, for example, is much evolved health system and medical education system in context of primary care, community-based services, and all. I'll discuss more about this. So in 2010, we founded Academy of Family Physicians of India to develop the academic family medicine specialty in India. It was there for a long time. Family medicine is a distinct discipline specialty as per the regulation of Medical Council of India, now National Medical Commission. It is there since 80s, 90s, and if you look at the PG regulation of National Medical Commission currently or previously Medical Council of India, it is mentioned as a distinct specialty of medical sciences in India for several decades, at least for 3-4 decades in India. So if you look in the list of the qualifications mentioned in the National Medical Commission Gazette or the regulation report, you'll see family medicine, community medicine, general medicine, forensic medicine as distinct and separate specialties. But for some reason, so I'll not go into those reasons why it was not evolved earlier, and why there's renewed interest now. Even now, what are the challenges and struggle for family medicine discipline? But our ambition was to evolve, get recognition as a distinct specialty of medical science, as a specialist, as par with any other specialty, promote research. So we started a journal and do professional training, raise the standards of practice of family physicians. And we did not want to be seen as the last generation of GPs, who were looked down upon as, basic doctors. We're just providing basic care or primary care. Many times we understand primary care as primitive care or trivial care, kind of impression is there in the mind. But I'll show you how different it is and what it means to be a family physician. And this is the global leadership of WONCA, World Organization of Family Doctors, when I was part of it twice. And we had representations from various parts of the world. Each continent has one representative. So there are 7 regions of WONCA. I was representing South Asia region, and earlier as young doctor representative of entire world on the WONCA board. And there I had good learning about health systems in different parts of the world. Just for the interest of audience, I also have a background in public health. I've done few semesters and coursework in public health before I started my DNB residency in family medicine long back. So I have a background of public health, understanding of public health policy development, advocacy, and all those things. And we need to also understand how similar, what are the overlaps between community medicine, family medicine, public health, and what are the distinctions, how they are different, how they are similar. So it is a traditional thinking that MBBS doctor is a family physician, which is true in intent, which is fine. But if you look at the career pathway of MBBS doctors as of now, there is a mandatory pathway of going through NEET and doing a postgraduate qualification. And in the overall intent, if you look at the recent discussions on talking about qualifying examination or licensing examination of next, which will be merged with NEET examination. The next examination will also be a qualifying or licensing examination for those doctors who qualify their MBBS, will be licensed to practice. But licensed to practice what? Obviously, a journalist having no knowledge and skills, competency of various disciplines would be a family physician or a general practitioner. But unfortunately, if you look at the curriculum of MBBS, it is entirely specialty driven. So all your medical trainers, teachers, professional advisors that you have in your environment of MBBS are all specialist doctors. You do not see any family physician, family doctor teaching in medical college, or as such, family medicine discipline is not introduced as such also. It is assumed that an MBBS doctor would automatically by default become a family physician or a family doctor or a general practitioner or a medical officer in a public sector. But those competencies, skills are not been given any identity or boundary of family physician. So nowhere in the curriculum it is written that the objective of MBBS training is to make family physician. And in practicality, what has become that without doing a postgraduate qualification, you cannot survive in the present times. So after doing your MBBS, it is mandatory to go through the PG entrance system, and then again it is a luck by chance, or we call it merit by choice, but it is entirely a game of luck. What you may have been wanting or dreaming all your lives in the beginning of MBBS or before MBBS may not come true. And by statistics, only about 20-30%. They say that there are 50% PG seats, but only 20-30% postgraduate seats are available in clinical discipline that we all wanted to be as a doctor when we started our MBBS course. And it would not be overstatement that all of us medical students who joined medical school or before medical school, all of us wanted to be a treating doctor. Doctors who see patients, doctors who treat patients, doctors who cure patients. So, in spite of all this specialty, which is, I call a semi-specialist course, and which is a qualifying course for becoming doctor nowadays because of the MCQs, the coaching culture. And it is very hard for a MBBS doctors to, become competent in sense of, a practicing physician at par with other specialists. And mostly what MBBS graduates now have, they have theoretical background, they have a qualifying examination, but I don't think there is competency, because right now I'm sitting in my clinic practice and I see a huge gap what I was as a MBBS student or a first qualified, and now where I've been practicing for several years. It is a huge gap of skill and competency that one cannot fulfill just merely by reading books. It has to be a vocational training practice. Without that, it is impossible that anybody would automatically become a practicing family physician. So other than the clinical part, there are many things they do not teach you in MBBS. They don't teach you financial management, they don't teach you legal framework. There is no not at all. Even Hindi, English, or any other language is not taught. There's no mention of language literature. Interprofessional skills and soft skill are being talked about, but largely it is very trivialized form, and mostly we learn from how our seniors, professors talk to each other, talk to us, and talk to patients, and we try to imitate those things also. History and society. We live in society, we serve our community, but there is a gap between the society and the doctors when we become professionals. And when we enter medical college, when we come out of it, we become somewhat different. I'm talking about these things because as family physician, you have to be one of the participants of the societal phenomena. You cannot be a different person from the common man, your community, your patient pool. You have to be same among them, and you have to know. And there's something called cultural competency. Unless you do not know about your culture, but what we see practically many times when we evolved as a doctor, we find our society antagonistic to ourselves. I mean, we blame society, we blame illiteracy, we blame on poor understanding of science and medicine, and we blame on the poor choices of the public. But we forget that we are also part of the same society, and if we have to be successful as a family physician, you have to know the culture, society, language, history, political economy, everything is very, very pertinent. You have to be a broad citizen, broad-minded citizen by yourself. Otherwise, it is very difficult for you to survive in the community as an independent professional. Hospital is a different forte where you are, all medical doctors, professionals, medical superintendent, administrative structure. Everybody is powerful, and they have a power imbalance where patient is or the community or the families who come to you or us are at the receiving end. But in the community, it is the society which is more powerful, and you have to be equally skilled in these competencies also, so that you can survive independently in community and your family practice. Entrepreneurship in leadership, because as family physician, like I practice in my own community, I'm independent. I'm my own boss, which means freedom, but also, it is responsibility in the sense that I have to make financial decisions for my practice, financial, professional decisions, managerial decisions, as well as right clinical decisions for my patients and the patients who come to me. Many times it is difficult because we all are trained in a way that we want to look for employment, work in a medical college, work in some organization. But we often find difficult because more or more medical colleges or students are going in India. There is hardly any campus interview. There is hardly any employment opportunities, and if at all, they are very limited kind. And if you look at across all disciplines, any medical college in India, there is no campus interview for anyone. You have to find your own path. So at times we are frustrated, but how to make change? We are not trained to that. Meaning of contribution, we all want society to treat us in a certain way with respect, with financial incentives. We want certain privileges from the society. And we often talk among ourselves what society has given us, what society should give us, what kind of income we should be generating, at least minimum. But mainly in a country like India with developing status, we should also think how we are contributing after we have among millions of people we have been given opportunity to become physician and doctor, but what contribution we are making back. These things are very, very important when you are a family physician. You cannot be a very cocoon kind of person who is working in a hospital, who is not bothered. Nobody knows in your own apartment what you are doing when you are going to hospital. You are a consultant, but nobody in your community recognizes you that you are a working doctor or a physician, because you are not working in the community. You are working in some faraway hospital. So there is a disconnect between the providers, physicians, as well as the community, and this has to be bridged. And this is one of the important roles of family physicians. So we have to think in terms of societal terms also, what contribution we have to make. I've already talked about family medicine as a medical specialty. It is a distinct and separate medical specialty legally. I'm not talking about conceptual things. I'm not talking about overlaps. कि मेडिसिन में तो यही होता है, कम्युनिटी मेडिसिन भी तो यही होता है, जीपी भी तो यही होता है, इंटर्नशिप में क्या होता है. I'm not talking about all those perceptions. I'm talking about legal perspective. Family medicine is a distinct specialty as per the regulation of Medical Council of India, now National Medical Commission, for several decades. So there's no, debate on this, why it is a new thing, old thing, separate thing. It is a distinct thing for a long, long time. So it's not about it is under part of which discipline, it should be, clubbed with what, and all those things. It is an academic discipline. How I will, share. It is a philosophy of care. Philosophy of care, because many things which are distinct to family medicine, because largely you are supposed to function independently in the community. This is a different philosophy. Specialty care is mostly an organ, gender, part of body, system of body. But family medicine philosophy is about whole person care. So many times people ask her, what are you specialized in? What do you specialize in? So I say that I'm a whole person specialist. I take care of the entire whole person, because a person, when we all memorize the definition of health, which is a state of mental, physical, and spiritual well-being, not necessarily absence of disease. So when we say mental, physical, and spiritual well-being, this encompasses the whole person concept. And this is only family physician's job which can do justice to this concept of healthcare. So it is a philosophy of care. It is a vocation. Like we all are doctors, physicians, orthopedic surgeons are also doctors. They are medical professionals, but they pursue the vocation of orthopedic surgery. So a public health person pursues the vocation of public health. A eye surgeon pursues the vocation of eye care or eye surgery. A genetist pursues the vocation of that discipline. So similarly, family physician is a vocation. One who is not pursuing the vocation of family physician cannot be a family physician. A orthopedic surgeon can, say that, yes, I do have all qualities and, understanding of family doctor. I advise my family members. I treat my patients very nicely. I talk to them very politely, all these things. But if you are not doing the work of family physician, if you are not working as the vocation of family physician, you cannot be a family physician. You cannot be a practitioner of family medicine. It is a service interface. So we all know, we have heard of terms like primary care, primary health care, public health, community medicine, family medicine. I will discuss these things in, if at all required, in the question answer session. But these are distinct things. I will talk more specific about primary healthcare and primary care. Primary healthcare is more in terms of first line of care in both medical non-medical terms. Everything in the context of public health. First line of care is primary health care. Basic sanitization, food, nutrition, everything comes under the domain of primary health care. But primary care, if you look at our journal, we call it Journal of Family Medicine and Primary Care. We do not call it Journal of Family Medicine and Primary Health Care. Why? Because primary care is more concerned about uh, clinical domain. It is a clinical domain. So doctors who practice clinical medicine provide generalist care across all age groups, are family physician, are practitioners of family medicine in community, and they deal with primary care. So it is the medical system or the clinical care provision in the community as a generalist physician, taking care of all age groups, genders, organ systems, has a specific interface in the healthcare delivery system. It is required. In public health sector, they are the medical officers, and in the private health sectors, they are the GPs or the family physician. I'm not talking about their position in the system. I mean the hierarchy, whether they are looked down as a basic doctor, where they are looked down as a, this is the hierarchical nature of the Indian society, that somebody has to be on high up, somebody has to be on the lower down. We do not see by the value what they are providing, what they are working as. So somebody who's working in community is not considered as powerful, resourceful, or valuable as somebody who is a super specialist. So I'll talk about those things, but this is a service interface we must try to understand. Well, why family medicine is important even today, why it is evolving, and not just because of I am talking, AFPI is talking, you are all talking, why it will evolve, sustain, or prevail. So this is a study from NEJM, New England Journal of Medicine. It was published long back in early 70s, 61. And it says that in any given population of 1,000 in any given month, some 750 people or persons will experience some kind of illness or injury. Out of this, we all know large number of them would be taking self-medication if it is very minor thing, trivial thing. Many of them will take medication from pharmacies and all. Only 250 of the 750 people would actually go to consult a primary care physician or a physician or any kind of provider in the community. Out of this, 250, only 9 require admission to any kind of facility, and 5 among this 1,000 or 750 morbidity require referral to a tertiary care center in a month, and only 1 requires admission to a teaching hospital, which is a medical college hospital. So if you see the actual value, the morbidity, it is 750, whereas what we see, the tip of the iceberg in the medical college where we are trained, is this one person. And this one person is mostly case of dialysis, end stage renal failure, end stage liver failure, stroke, MI, and this is what we are trained on. But what family medicine deal with is this 250 morbidity, which is huge in number, which is often unaddressed, and it is also financials in itself. Something which is being done for one person at a tertiary care, it is not only expensive, it has implications in terms of the aggregated value of the opportunity for practice. So this 250 opportunity is huge, and I am sitting in my clinic. I can assure you that practicing as a family physician is, and I'm talking about entire NCR, and it is much more financially beneficial to practice as a family physician than to work as a consultant of any discipline in any hospital of Delhi. So this is the study is called ecology of care, where majority of the community-based morbidity is still neglected. And the same study was repeated, published in the same journal, and the findings were same in 2001, and the situation remains the same. So this is just for fun. A goat is tied with a 2-meter grass, and grass, 2-meter rope, and grass is kept at a distance of 10 meters. How does the goat eat the grass? So there are many explanations that grass will break the rope. Somebody will bring the grass to the goat. Many explanations when we talk face to face. But the answer to this question is the goat cannot eat grass if the distance between rope and the grass is too much high. And this is the situation of the medical students. So all of us are trained on that one person, one person who is admitted to a tertiary care medical. Our entire training, mindset, environment, micro, macro environment is tertiary care. And, we do have some community-based exposure during our community medicine posting, but largely it is dominant tertiary care training. And this is the reason why medical students do not opt for community-based services, rural services, or try to become independent practitioner. Number one, they have never been exposed during their MBBS curriculum what is family medicine, what is family physician's job, what does a family doctor works like, what is the practice of a family physician like. Like I have my practice, I am sufficient. I mean, I can train many medical students, but technically I cannot be a medical teacher when I'm working in a primary health center. I'm working in my own clinic. We had invited Professor David Ment from Oxford University during one of our conferences, and he's a professor at Oxford. But where does he work? He works at a primary health center in UK. So a doctor who is working in primary health care center can become a professor, but in India, regulation is such that only if you have a tertiary care exposure, if you have not worked as a senior resident in a medical college, you cannot become an assistant professor also. So this is some kind of a paradox whereby through rules and regulations, we have skewed our medical education system that we do produce doctors, but they will not go into the becoming vocation of primary care or family practice or community-based clinical care, because this is not inherently included in the MBBS course itself. Now, these new departments of community medicine and family medicine have come up, but there again, you see your MBBS course did not have any content of family practice. Why this has happened? Because this has happened because of the repeated neglect of the respective councils, medical council. Even today, National Medical Commission is responsible, but they are not doing it mandatory, because there is Department of Physiology, Biochemistry, Anatomy, and 20 other departments in MBBS course, because they are mandatory departments to start a medical college. Family medicine is not listed as a mandatory department to start a medical college regulation. So there is no department of family medicine, but no other department can play the role of a family physician, faculty, teacher, or ambience, environment. So what my training can do, or what a family physician's training can do, has never been the part of the curriculum as well as the clinical exposure. So this is the dilemma of medical doctors. We often blame the MBBS students, but they have never been exposed. It is not their fault. It is the fault of the regulators. And this is what medical education, our medical education system, makes us to see human health. So if you go to medical college hospital, you see, departments of different organ systems, organs, genders, and all those things. And this is how, a qualified doctors starts to see human health like. It's like we all have heard the story of wise man and the elephant. And this is fragmented care that we all thought of. Not go into detail of the emergence of medical specialties. It started in France, Paris. This is a study how specialization started. And this is also a very negative phenomena of uh, our medical education system or healthcare delivery system, where we have hierarchy of service providers. Nowhere in the world where people are identified by their qualification. The value of a primary care physician, family physician cannot be compared with a super specialist. These perceptions have been built in the idea around that somebody who is repeatedly qualifying entrance examination MCQ based is more knowledgeable, is more intelligent. This is not true. If you are a musician, if you are a good scientist, if you are a good multi-dimensional all-rounder person, you may not be very good at qualifying multiple choice questions, but that does not mean that you are a lesser intelligent person or low qualified person, or but this is the hierarchy which is ingredient part of our Indian society also, where somebody has to be top of somebody else. So nobody in the if you go, the value of GP in UK is more than value of a specialist in UK system. Everybody goes to UK and tries to become a GP. All Indian doctors, a large number of them go and become GPs there. I have known people who have done their, OBG, ENT, surgery. They have gone to UK and have become GPs. So this arrangement kind of, gives medical students and, peer understanding that you have to have, and this is a rat race of where people are doing MBBS, then they are doing entrance examination, doing medicine, and then they want to become cardiologists. And when you become cardiologist, you see there's no campus interview. Even if you are MCH, CTVS surgery from AIMS, anywhere in India, you don't have a job of 5 lakh rupees. There is no campus interview. There is no demand for you. You just have to find your way. And many times we see them struggling in the large metropolitan cities just to find some work, government, private, and everybody is looking some kind of salaried support. So this is a very unfortunate situation. So medical doctors, 40 years experience, you are a basic doctor, you do a 3-year MD course, and you become a Prince Charming specialist doctor. Specialist doctor is perceived to be more skilled. These are all perceptions, not necessarily the reality. Professional recognition, social prestige, higher monetary compensation. This is not true, because as I said, there is no comparison interview. If you look at the recently qualified DM, MCH, MD, everybody's income is almost similar. And we have been never told about the other pathway, which is the pathway of the generalist. We all know about becoming specialist. And it is important that apart from having depth in knowledge, we also have range in knowledge. And range, generalism is very, very important. If you compare the skills of a specialist and generalist, you look at this diagram, the horizontal surface is the interface of a family physician or a generalist. The vertical lines are those of specialists. You cannot compare these two, who is more knowledgeable. Each of them have a different interface, different knowledge requirement. They serve different situation and context of the patients. So generalism is the most important foundational concept of being from a family physician. So although family medicine is a specialty, we call ourselves generalist. We are not specialists in the terms of that we look at very particular things. When patients come to me, I see diabetes patients, thyroid patients, infectious diseases, abscess, burn. I've diagnosed MIs in my clinics, CBD stones in my clinics, accelerated hypertension, all kinds of urgencies, emergencies, common problems come to our clinics. And it should be my competency to treat 90% of those patients with positive outcomes. And this has been proven in various reports, results, that 90% of the clinical morbidities encountered, I'm talking about those 750 cases, can be treated efficiently by a trained, competent family physician. And this is the CANMED medical expert definition, which is you have to be communicator, professional, collaborator, manager, health advocate, scholar. And these all 5 domains can be only best justified by being a family physician. And a medical journalist is a multi-skilled, as I said. I can see pediatric patient, I can see geriatric patient, I can see palliative care patients, I can diagnose ECG, MIs in my clinic. I can, provide care to a person presenting with renal colic, cholecystitis, cholelithiasis, pain abdomen, uncontrolled diabetes, uncontrolled hypertension in the clinic. All those things I do in my practice in a day-to-day life. I'm not driven or bounded by a specialist domain. I don't see that I will not see child because it's a pediatrician job. I don't say that this is a looks like some fungal infection. I'll not treat it. Go to a dermatologist. I don't say that your blood pressure is 170 by 110. I will not treat you. I don't say that your fasting sugar is 250. I will not treat you. Go to an endocrine person. I treat all these patients with equal level of competency because in today's time, everything is evidence-based. And if I am accustomed and used to, and I've learned the common clinical guidelines of diagnostic criteria as well as management goals and the clinical guidelines, I can treat all these patients at par with any specialist. So treatment of a diabetic person has to be, it can differ from the patient's perspective. Two patients can be different, but the treatment by two doctors cannot be different. It cannot be provider driven. The evidence-based treatment by a MBBS doctor, by a MD doctor, by a family medicine doctor, by a community medicine doctor, by an endocrine doctor of a diabetic patient has to be same because it has to be patient-centered. And just to see, we all have understood, internalized that super specialist is the most intelligent person in the system. It is not true. The genius of all time, Leonardo da Vinci, we all are told that jack of all, master of none. This is not true. Human brain is unlimited. And we all know Leonardo da Vinci was a painter, sculptor, architect, musician, mathematician, engineer. So genius of all time was a generalist. These are the generalist people. Rabindranath Tagore, these people, generalists, most intelligent people are called polymath. They are not called super specialists. A super specialist cannot be a genius. They can be master of their art, craft, or what mechanically they are doing. But person like Rabindranath Tagore, who was a journalist, who was a polymath, who was a poet, who was a musician, music composer, he was artist. His drawings are still kept in Shanti Niketan. I've been there and I've seen the work of, and we all profoundly know how genius Tagore was. He has written national anthem of 3 countries, including India, Bangladesh, and Sri Lanka. So these polymath geniuses, and we in medical science have an understanding that different understanding of genius. Genius is not one who is doing cracking MCQs and who is doing super specialist work. Now, what all family medicine career pathway is available in terms of roles and responsibilities. Specialist family medicine. And these days, those who have done their PG qualification, they call themselves as specialists in family medicine. They go into academics, mostly all AIMS-like institutions and many other medical colleges like Calicut, St. John's, CMC Vellore have their independent department of family medicine. They can do independent family practice like me, I am doing, community hospitals. Easiest way to start a nursing home or a small hospital in a community is by being a family physician. Public health and primary care sector, family physicians also know, like I have seen, hundreds of patients of, influenza recent strain by myself since October. It has only started coming in news recently in February. But I was seeing this different pattern of influenza in my clinic since October. It has been 5 months now. I've seen the dengue cases, real dengue cases, which was not, screened in the surveillance system of the country. I was seeing the real pattern on the ground of the COVID diseases, the different strains of COVID, how they are functioning at the ground level in my patients. So I, as a family physician, also have, my role in epidemiology. I see chicken pox. I've seen hand, foot, mouth diseases. I see tuberculosis in the patient. So all these have connotations and cross pathway with the public health system also. This is best because you are a journalist. In a rural area, you have to be a surgeon, physician, gynecologist, orthopedic surgeon, everything. So family physician's role is best as a clinician in the rural practice. And many people have been on pathway of innovators and social entrepreneurships. They're doing, like I've involved myself with the Academy of Family Physicians of India journal. as well as I'm also co-founder of a company which is called Doctor at Home, and we provide real-time live vitals and medical evaluation parameters from home and connect with the doctors. So now I'm concluding towards the session, and these are the foundational concepts in terms of roles and responsibilities. Family physician is the first contact. So when somebody has the headache, they have option of going directly to the neurosurgeon or a neurologist, which often people go to. But if you go by the DD or the differential diagnosis, headache could be because of simple hypertension. It could be because of fever. It could be because of dental problem. It could be because of vision problem. It could be because of high level of sugar. It could be because of sleep deprivation. Any of these causes could be causing headache. Now, if the person directly goes to the neurosurgeon neurologist, he or she will order a MRI and then, say that this is a dental problem. This is a eye problem, and this does not look like a neurological problem. I worked with my DNB guide was a neurologist. He was also president of Neurology Society of India, General Venkatraman, and I was I shadowed him for 1 year in his neurology practice. Large number of them were only headaches and epilepsy cases, and from that experience I can say that going someone identifying headache with neurology is a flaw, is a fundamental mistake. So first contact person is a family physician who sees the patient. 90% of the times it is a curable thing, simple fever, sleep deprivation, fatigue kind of things, and this can be managed by the family physician itself. Only in the rare 10% of chances you need referral to a dentist, to an eye surgeon, to a neurologist. It is whole person care. I've already discussed person centered. As I said, that every person's diabetes is different. Every diabetic person is a different gender, different age group, different stage of diabetic evaluation, different type of insulin mechanism or medicine. So the disease or the treatment has to be tailor-made. It has to be personalized. It cannot differ based on the provider's qualification. It is family-centered care. Family-centered care means every family has a different food habit, lifestyle, income level, and your treatment has to be tailored according to the family structure. Some are single mother families, some are joint families. Some people are eating too much from outside. Some people are vegetarian. Some people are non-vegetarian, and these are all family practices. And family, in my understanding, is the foundation of the society in Indian context, because all of us live in our families. We live in our communities, we live in our caste, we live in our religion, we live in our locality, but primarily we live in our families. So it is family-centered care is very, very important. Community-oriented care is, of course, a community of slum is different from a community of South Delhi or South Mumbai. A community living in rural Bihar is different from a tribal community living in Nagaland. A community living in rural West Bengal is different from a community living in rural Jharkhand. So these communities have different sources, different belief systems, and we have to orient our care according to this. The foundation of it. It is life cycle care. Life cycle care is also foundational concept, because we provide care from antenatal to end of life care. People come us for infertility problem also. They come during the pregnancy period also. A lot of cases I'm seeing recently are of influenza-like illnesses in their 4th month, 5th month, 6th month pregnancies. So now these are comorbidities. The woman is pregnant and she also has influenza. Many times they may also have hypertension. So all these problems can be solved by a family physician in life cycle care. And sometimes women come and then say that, look, my child is also not well. Can you advise something for it? Yesterday, a woman came for gastroenteritis, and and later she asked me if I can also. She's a dentist. If I can also advise her from a skin problem. I said yes, I can advise for the skin problem also. So across discipline, age, gender, we provide care, and this is life cycle care. No other discipline does this better than family physicians. Ecology of care, I've already explained. Continuity of care is very important, because mostly if you are working as an intensivist in ICU, there is hardly any chance that once the patient is discharged or died, you will ever meet that patient or the family of that patient ever in life, because it is transactional care. It is, once in a time care contact. Mostly this is happening in the hospital setting, but in a family physician setting, the same person comes in continuity. For example, repeatedly for diabetes, again for hypertension, then for some skin problem, then for some family related problem, then from some sleep problem. So patient is continually coming to you back and again for different problems, and this continuity maintains your relationship with patient. And this is when we say, we have a decline in doctor patient relationship. It is decline of the family doctor tradition which is causing the fault in doctor patient relationship, because majority of the care is being delivered at the hospital emergencies or ICU, and that is where not the doctor patient relationship happens. It happens only in the community setting between a family physician. When there is no family physician, there is no doctor patient relationship. A super specialist cannot make a doctor patient relationship. He can make a good client satisfaction, but no doctor patient relationship without continuity of care. Medical generalist, I've already explained. Managing complexity. A person may have multiple problems. Somebody may be poor, diabetic, poor family structure, undergoing divorce. These are the complex situations where we have to handle it. But as a hospitalist, you are not bothered, because if you do not have money to be admitted, I'm not bothered. If you don't have money to do MRI, I'm not responsible. But as a family physician, when people come with their problems, I am responsible for all these things. And then the scenario of complexity come into place. Multimorbidity. A person having diabetes will have neuropathy, constipation, vision problem, memory problem, locomotor problem, dental problem, urinary problem, sexual dysfunction. All these problems are multimorbidity. If they visit for all these problems to different departments in a hospital, it will be a chaos for them, impossible. And this is one of the reasons why many people cannot access to healthcare properly. Now, long-term care is also important, because once someone is diagnosed diabetic at the age of 30, it takes several decades of their lives to be taken care of in different stages. All diseases are not end stage. So long-term care is required in chronic diseases, cancers, chronic liver disease, chronic kidney disease, and all this managed well in community by family physician. Clinical prevention, we all know preventive medicine, preventions of the national health programs and all these things, hygiene. But how to practice prevention in clinical practice? Now, most of the people nowadays do health checkups. So all these clinical things, clinical parameters are to be dealt with according to the clinical practice guidelines. So these, for example, have guidelines in US, which are US Preventive Task Force guidelines, Canadian Preventive Task Force guidelines. India, we do not have yet, but this is the at what time, what age, what chemoprophylaxis, what screening test, what medical intervention has to be done at different age group has to be evidence based. For example, you do prostate test at a certain age, not at the age of 30. We do TMT at a certain age, not the age of 15, right? So this has evolved, and these are clinical practice guidelines. And many times the whole body checkups or the clinical profiles that are being offered by different labs and all, these all come to us in clinical practice. For example, they come to us, Dr. Saab, my uric acid is raised, my triglyceride is raised, my iron value is low, my CRP is high, my HCRP is high, my creatinine is slightly raised, my liver function, SGOT, SGPT is raised, what to do. These all things come in clinical practice. Reducing someone's lipid or cholesterol by medicine, lifestyle, diet, moderation, all this comes role of family physician. How to reduce uric acid with medicines, with preventive, with lifestyle changes. How to reduce SGOT, SGPT when there is no jaundice, it's only clinical hepatitis or low-grade hepatitis kind of situation. Fatty liver, which is commonly seen nowadays in ultrasound. All these come in the domain of obesity, domain of smoking cessation, alcohol dependence management. all these come in the domain of clinical prevention. All the screening tests, cancer screening, they all come in the domain of clinical prevention. And lastly, home care. Home care is in entirety is the role of family physician. We all have seen in cinemas, movies, the doctor coming with the bag. This has again come up again during the COVID times, and largely in the second, third waves of COVID, patients were managed in their home. Now they are added with teleconsultations. All these functions are the functions and roles of the family physicians. So this is briefly about evolution of family medicine discipline in India. And family medicine is recognized as a separate, distinct specialty since 1980, when National Board of Examination was formed. It was an amendment in MCI Act, and family medicine has been mentioned in National Health Policy 2002, 2005. New regulation was found, and 2010 Academy of Family Physician was founded. 2012 Journal of Family Medicine and Primary Care was founded, and we organized our first national conference in 13. And National Health Policy 2017 again has mentioned family medicine discipline. And World Rural Health Conference we organized in 18, and we put petitions to PMO, Supreme Court of India and all. And now we have a specialist board in family medicine at National Board of Examination. And in National Medical Commission Act, it has been mandated. Earlier it was policy. Now in the Act, it has been mandated that the role of UG board and PG board is to promote discipline of family medicine. This has not been sent. So now Act cannot be breached. So if NMC does not implement, it is breach of the Act, law of the land. So it will happen in due course. And this is why now there are movement, even in new AIMS institutions. Initially, they created Department of Community Medicine and Family Medicine. For some reason, family medicine component was never supported by these departments. And now this is the reason why the MD family medicine has now come up again in the issues of national importance. And now at least 5 or 6 medical colleges in India are offering MD family medicine already. There is Department of Family Medicine at PGI Chandigarh. The other medical college which are offering MD family medicine are Calicut, the first one, NRI Medical College Guntur, St. George Medical College Bangalore, CMC Vellore. All these are offering having 2 to 4 seats for last 10 years or so. So first one, 2011-12, was started in Calicut Medical College. It has been a decade of their department already. So these are the shared principles of primary care. I've already explained how primary care is different from primary health care, right? So there should be no confusion. I can clarify the overlaps and similarities or dissimilarities between public health, community medicine, family medicine for interest, but I can do that in the question answer session, not now. So family medicine is the rise of the medical generalist, and this is the role of family physician. And because everybody is so competitive nowadays, everybody wants to become a super specialist. There is plenty of scope financially, career pathways. And it is not because we are pushing for family medicine, it is because of the population of India and huge morbidity. 1.3 billion population, such a big morbidity, we cannot address only through the hospitalist piecemeal system or selective primary care system of the national health programs. And this is the reason why, in spite of having all these expenses, medical colleges, medical system, large number of doctors, we are not able to address the needs of the people. So if the needs of the people have to be serviced, the role of the family physician has to be streamlined in the mainstream, which has been sidelined because of the various factors, which I can discuss later. Thank you very much.
Thank you so much, sir.
So lastly, last point, we are trying for accreditation of family practices, standards of care, networking, practices. Imagine 2 lakh family physicians network together through a digital platform in tandem on the same clinical guidelines. What a strength and power they will have. This is the journal. We have been doing high level advocacy. This is advocacy at the global level. Our WONCA president with WHO Director General. We organized the World Rural Health Conference. Thank you very much. I'm done with my talk. So if you
Yes,
have
sir.
any questions.
Yes, sir. Thank you, sir, for such an enlightening session on family medicine. And really, the people who have joined today, those who didn't have any idea what family medicine is about, sir, you have brilliantly explained that. And just for sensitization, I think this has helped a lot of people to get clarity on this branch. So I request everyone, every participant, if they are having any doubt or their question, they can just type in the next 5 minutes, and I'll try to address majority of them. So till then, sir, I, as a moderator myself, I have some 2, 3 questions. So I'll just put forward to you, sir, that you said that somewhere the system is flawed, that family medicine has not been incorporated or supported yet from the MBBS level. So,
Yes.
how can we incorporate MBBS? What is the vision that you have? Exact vision that you have, that how MBBS can incorporate family medicine?
Right. Why do we have Department of Physiology in MBBS? Why do we have Department of Medicine? Because these are all governed by the regulation of National Medical Commission, earlier by Medical Council of India. There is a regulation, there is a book of National Medical Commission, which is called How to Start a Medical College Regulation. In this regulation, they have mentioned medicine was added. Hello, can you hear me? Hello, can you hear me?
Yes, sir. Yes, sir. I can hear you, sir.
Okay. So by that regulation, it is a inhibitory. It has an inhibitory effect on family physician. Now, people say that if family medicine is so important, if it was so useful, why there are very less number of seats or PG seats till now for several decades? It is because only a MBBS department will apply for a PG department, right? Department will of orthopedics, when it is there in the UG department, it will apply for a PG department. Anatomy, if there is there at the UG level, it will apply for a PG department. There's no such department which will apply for family medicine. So they try to grow it on some department, some places like DNB programs. Mostly it is the medicine consultants who are taking care of family medicine thing. It is overlap with general medicine department and DNB courses most of the places, right? And even in the MD courses, it was the medicine department which were initiated. So unless there is a UG department, mandatory UG department, there cannot be a PG in family medicine. So, and to our understanding, PG, more than PG, it is more useful for the MBBS. No, you are expecting MBBS doctor to become family physician without any training in family medicine.
Right,
So
sir.
one of the things we are demanding is to change the regulation and include family medicine in the list of the mandatory departments for how to start a medical college.
Okay. Okay. Thank you, sir. So the next question to me is how you have said that one of the streams that one can take after doing family medicine is entrepreneurship. So, in what kind of entrepreneurship can you give us some examples that one can do after pursuing family medicine?
If you look back in your previous generation of medical professionals, many doctors used to practice independently, which is now in decline, and large number of doctors are now employed. Even if they are specialists, they will work in some corporate or some government medical college or so. One of the medical doctors are professionals. There are 4 or 5 types of people who are considered professionals: advocates, doctors, chartered accountants, architects, and they have also a different law for their taxation in the society, in the system. Now, one of the first journey towards becoming entrepreneurship is gaining professional and financial independence. If you look back in my one of the slides where I say that what they do not teach you in MBBS is, one of the things is they do not teach you finances. Most of us don't even know when the message, you get message of credit and debit, you do not understand ki ye paisa aaya ki gaya, right? So financial independence is the first thing. And the initial step is to having your own practice, where you can be your own boss, where you can run your own practice. First step in the smallest unit is having independent professional practicing in her or his own, premise, without any interface from external, without any external funding, without any government control, without any private management owners direction. You can function by yourself. So that is the first level. And large number of doctors, others are now working on other facilities like digital healthcare applications, home healthcare. Large number of entrepreneurships have come into those domains only. For that, you need to have sufficient, first and foremost is financial education and a bit of legal education, how to start a company, how to start a, everything is given in the law. But, we want to take some permission, some power, some position of a senior resident, position of an assistant professor, position of a dean or director. But by law, you can start your own system by starting a company. Now, how to start a company? That has to, be learned. And, initially, I would say it is only having your independent practice, financially independent, is first step of entrepreneurship.
Thank you, sir. Sir, a question has come up from the audience that what is the role of a community medicine faculty in a family medicine specialty, and how to, as you have said, you have told about some vision of the development of the department, but especially in the AIM settings, that is the departments of community medicine and family medicine. So what can a community medicine specialist or a faculty do to enhance the component of family medicine for the training of PGs?
So, I mean, by training or by licensing, all community medicine persons are licensed to practice. But by convention and tradition, most of them are working in policy sector, program sector, or teaching. And most of the community medicine faculty, senior ones, do not engage in any kind of clinical work. So mostly it is residents, medical officers who are doing, urban centers or rural centers, and others are just taking data, publishing, doing evaluation, participating in, public health meetings, or doing consultancy with WHO and other organizations, kind of thing. And largely, they are not doing any kind of clinical work. So we have to first, if you take strength and your weaknesses, then the weakness is, most of the senior faculty have not been doing any kind of clinical work. If you look at across any professor, nobody is seeing any patients, sending. So this is one of the weaknesses. So, if you want to be, strengthen the part of family medicine part, one of the things is you have to try to become a clinician, start seeing patients also. And that will kind of, support or kind of, help you in getting better career prospect. You can also become an independent practitioners also. I know many community medicine physicians. I know one from Dr. Kishore Madhwani, who practices as a family physician in Mumbai. He takes home calls and he charges 15,000 rupees also in Mumbai for one home call. And he's an out and out family physician. He's a community medicine MD from Wardha. There are several other persons like that, but those are exceptions. Some places like Wardha, AIMS Ballabgarh or CMC Vellore, they are providing clinical care in the community, but largely departments are only doing, public health synonymous work. And this is important that all those who are interested in family medicine should also do clinical practice. This will strengthen your financial position also. You can be independent. Otherwise, you are always dependent on your teaching jobs.
Okay, sir. Thank you, sir. Yeah, sir. Anything else that you'd like to say?
No. So that is fine. But if you want me to clarify why family medicine and community medicine are different terms, because many times we hear that especially from senior faculty, ki community medicine to wahi hai, family medicine hai. फैमिली मेडिसिन तो एक सब स्पेशलिटी है कम्युनिटी मेडिसिन का, या दोनों एक ही चीज है, वो हो ही रहा है तो फिर अब इसका क्या जरूरत है, काइंड ऑफ थिंग्स. तो इसके लिए हमें थोड़ा सा फाउंडेशनल अंडरस्टैंडिंग जरूरत है. आई जस्ट टेक 1 minute बिकॉज इट इज इम्पोर्टेंट फॉर all community medicine person to understand why family medicine was not established in India, why community medicine was given as a department in India, why historically this has happened. We all know Bhore Committee report. We all read in textbooks. That is about comprehensive healthcare system, right? From primary to tertiary. We all have read 1946. And then this was based just before independence. At that time, NHS of UK was being formed under the Labour Ministry. Medicine is Almata Declaration, which is again about comprehensive primary healthcare. Right? This is our teaching. That our role model is Bhore Committee, Almata, and we have been trying to do after that, Millennium Development Goals and now Sustainable Development Goals and all. But we never followed the Bhore Committee report in India. We also never followed the Almata Declaration in India. Immediately after Almata Declaration, there was a conference in France by Rockefeller Foundation, where they called for selective primary healthcare. Comprehensive primary healthcare means anything that comes in health system, we will treat it. Like in NHS, where GPs treat any disease, any problem. They do not have vertical health programs. But in India, the Rockefeller Foundation and later on WHO promoted selective primary care, which meant national health programs, vertical health programs. Right? And for that, it was not comprehensive. They created community medicine departments. So largely, it is vertical health program, management, promotion, academics in that term. Contrast to that, family medicine was like NHS of UK, where you have comprehensive healthcare, comprehensive primary healthcare, any disease, any problem that comes to us, we will treat it through like that. So these are contrasting concepts. And this is why to promote selective primary healthcare, family medicine was never given due space, because we never wanted to create NHS. We never wanted to create NHS in India. This is the historical background. We never followed Almata, we never followed Ore Committee report. But our system was based on selective primary care, which we call now largely known as national health programs, vertical health programs, and for which community medicine department was designated to run it and govern academics, through academics. Right.
Okay, sir. Sir, two more questions that has come up, and one, Dr. Ashish Arya has said that he's a DNB diploma student of family medicine. And is there any secondary DNB course for 2 years course equivalent to the degree of, the bachelor's degree, the specialist degree of family medicine after completing the 2-year diploma?
So
Is there anything like
previously,
that?
there was no diploma in family medicine. This is the first time, recent, 2 years back, when I became the convener. At that time, we were given responsibility to start diploma program also by the ministry. So now, earlier we did not have any diploma, so we had secondary DNPs, but that was through for IGNU people who were doing geriatrics, MCH and all. But now we have a diploma for sure. We will have degree, 2-year degree programs also in due course of time. Hopefully, very soon it will be announced.
Okay, sir. And the final question is, the family physician who has done DNB family medicine, they have done 3-year SRship in medicine. And so they're asking, can they become an assistant professor in the Department of Medicine if they want after doing that 3-year SRship?
Legally, no.
Legally, no. Okay. Okay. Thank you, sir.
Okay.
So that was the all for the question and answer session, sir. Thank you very much. So now we will I would like to invite Dr. Abhishek to give the vote of thanks. Over to you, Dr. Abhishek. Abhishek, you're muted. Yeah.
Hello, am I audible?
Yes, you are audible now.
Thank you, Dr. Ria ma'am. Good evening to all of you. This is Dr. Abhishek Rath. I'm the General Secretary of IACFM. First of all, it is a great honor and privilege for me to propose the vote of thanks for this webinar. And first and foremost, I would like to thank our guest speaker, Dr. Raman Kumar sir, President of AFPI, Association of Family Physicians of India, who despite his busy schedule has found time to give us such a valuable and informative speech on the topic and enlightened us with the vast amount of experience in the field of family medicine. Thank you very much, sir.
Thank you. My pleasure.
Thank you, sir. Next, I would like to thank all our team members of IACFM for their relentless efforts in making this webinar a success. Especially, I would like to thank Dr. Ria ma'am, our executive member, and Dr. Rubina Sa ma'am, currently she's acting our vice president, who have played an important role in providing this association a strong leadership and foundation that it needed. Thank you, ma'am. Next, I would like to thank our participants who participated in the webinar, without whom this webinar couldn't have been a success. And getting such an overwhelming response from the participants at this nascent stage of our association, it gives us a lot of thrill and excitement to conduct more such webinars in future. Thank you. Nonetheless, I would like to thank our digital partner, the ClearNet team, for having provided such a enthusiastic and cooperative technical team whose relentless efforts has been a pivotal role in making this webinar a success. Thank you very much. So with this, I would like to conclude my vote of thanks speech, and I would like to request Dr. Rubina ma'am to take over. Thank you.
Dr. Rubina is requested to have the closing remarks, please. Thank you.
Hello, good evening all. I have some voice issues because of my viral infection. Thank you, Dr. Raman sir, for giving us an opportunity to take to make people aware of what family medicine is. So family medicine, as per me, it was envisaged with the vision of encouraging general practice. In other words, taking care of entire family's health. A family physician's job is not that easy as it looks. They not only have to take care of the health in unidirectional way, which is the curative, what we call through medicines, but it is also a holistic approach. By means, you have to prevent the disease. If the disease occurs, you have to cure the disease. If you're unable to cure the disease, you have to take care of the rehabilitation. One always wants to cure a disease, what sir has told, like everybody's following the specialist's care and not the generalist care. But can patient be treated in that way through only medicines? One has to understand that. Even I think the people who are practicing these days as a primary care physician as well as specialist, they are more into giving medicines rather than giving counseling to the patients, rather than preventing the disease. So that is what is lacking. So maybe because of that, the generalist, what sir has perfectly said, the generalist has arisen. And I think in future, the future looks good and promising for the family medicine. And I hope the medical colleges of India understands this and they start this inculcating this practice through in MBBS curriculum. Like AIMS is one of the institutes which has inculcated some of the family medicine component in its community medicine thing, like, and became a community and family medicine. So I hope that in future looks good for family medicine people. So this branch will certainly flourish, I feel. And I would really, from my bottom of my heart, would like to thank Dr. Raman sir for accepting our invitation, and even the AFPI team, the entire association, the Academy of Family Physicians of India, to help us organize this CME and get CME points, which is 4 CME points we have got through the Bihar Medical Council. And I would like to thank the Bihar Medical Council as well. And I would like to thank my IACFM association members as well as the core committee members. Without their joint effort, this webinar wouldn't have been successful as it is successful, as we have got around near about 170 registration in less than 5 days. So it's a big achievement for us in the last 2 months. We have just, this is our third webinar on a row. And if people think, why are we going for an MD family medicine? not any other subjects like MD internal medicine, MD MS general surgery. So I would like to give one example of Dr. Bidhan Chandra Roy. Everybody might have heard about BC Roy Awards, if who are in the medical field, or everybody might have known about Bidhan Chandra Roy. He was one of the chief minister of West Bengal. He was not only a physician but also a surgeon. He did his MRCP as well as FRCS. So by this, I would like to conclude that hope the family, many people who are from MBBS comes with this ideology that they can seek for MD family medicine as their career perspectives, or as a DNB specialist in family medicine. So I would like to thank everyone and would like to congratulate once again everyone. So right, I'll give the mic to Ria to conclude the session.
May I come in again for 1 second?
Yes, sir.
Okay, so thank you. I want to thank you all for inviting me to this opportunity to interact. I'm sure all of you being part of, having a component of family medicine, you all are deeply, committed to family medicine. And it works well if we all work in collaboration. So I'm glad to see you have founded your organization, which is AFPI, because it is a, again, a different disciplinary, offshoot. Let us see how it evolves, but my submissions would be like we work in collaboration. We can have collaborative memberships also. So if we, organize things, you can be part of it. And you also take membership of AFPI. Others who are interested in your organization may also take membership. Like we work with older generation of family physician, AFPI, IMSCGP. Today only we had a program with FFPI, they're Ahmedabad-based family physicians, so older generation without PG, but they are good in academics. And we organize a combined, kind of thing. And we are also working on a organizational kind of, setup where we, work together, so that our end objective is met. Right. So I invite you all to become members of AFPI also. Thank you.
Yes, sir. We would be more than glad and happy, sir, to work in collaboration.
We are working in many different organizations. I'm also a member of IMA. I am also a member of FFPI. So one person can be a member of different organizations, multiple organizations. And wherever you see opportunity to work and strengthen the concept, you do it.
Yes, sir.
Okay.
Yes, sir. Thank you, sir.
Thank you so much, sir. And thank you, Dr. Rubina. Thank you, Dr. Abhishek, and thank you to the Clernet team for helping us carry out this wonderful session. And IACFM is very glad to be a part of it, along with the support of AFPI. Sir, very much thank you, and we would love to collaborate with you. And also, I'm thanking Clernet team. We would love to collaborate you and continue this collaboration in the future. And hopefully, many other family medicine sessions will come up with collaboration with AFPI, and we can plan that for the benefit and welfare of all the MBBS as well as the PG students who are interested. Thank you. So I'm handing over to you, Ankana.
Thank you all for sharing such valuable insights. We're more than grateful to everyone present here. We hope to have you again at our platform very soon for the next session. Thank you all. So with all your permission, we are signing up the session here.
Yes. Okay, sir. Okay. Thank you, Ankana. Thank you, sir.
Thank you so much, ma'am. Thank you.
Thank you, Rubina. Thank you, Abhishek.
Thank you all.
Thank you, everyone. Thank you, everyone.